Thank you for introduction and to all in audience. I would like to say something about do we really have a novel treatment approach to avoid re-thoracotomies in cardiac surgery? So I'm coming from Croatia, from capital Zagreb. This is my hospital and my university in which I'm working. And few words just for introduction. We know that dogs in a wide usage from 2008, and we have several types of dogs. It's primary inhibitors of 2A and also inhibitors of 10A, part of the coagulation system. And another one medication is Ticagrelor. It's a platelet receptor antagonist, and it is also used for the in everyday practice for the many time. Recommendations before the surgeries is that we have to discontinuing dogs 24 to 48 hours before surgery, and for the Ticagrelor that recommendations is at least 5 days before surgery. But sometimes elimination half-life of dogs and Ticagrelor, it mostly depends of decreased renal function. Also, it depends about the liver function. And we know that the both can be in older age patients and that we have a problem in the older patients. And most important from my point of view, like anesthesiologist, is that we have very high interactions between these drugs and primary anesthetics. And in that case, we can have the prolongation of drugs or Ticagrelor effect during the surgery. What we have to do before surgery is, yes, that we exclude clinically relevant concentrations of drugs before a high-risk bleeding procedures, and the cardiac surgery is a really high-risk procedure, and exclude supratherapeutic plasma concentration before urgent interventions. And unfortunately for that, we don't have a real good global assay exam, which by the which we can get a result about the activity of drugs or Ticagrelor in the plasma and serum of our patients. Also, TEG or TEM, couldn't be good methods for the exams because we don't have a standardization and don't have insufficient studies. Still, no, we don't have a specific correlation assay widely available for the patients on drugs and Ticagrelor. And for the Ticagrelor, American Society of Anesthesiologists 2 years ago recommended 2 tests, but unfortunately also that the test is still not in the right usage. We have a few questions like what we can do in elective versus emergency versus urgent surgeries. And the main question could be, can we postpone the surgery in that moment of that patients? For the elective surgeries, sometimes it's a huge problem because the patients could be admitted in hospital just 1 day before the surgery. And sometimes they forget to discontinue this therapy. Urgent surgeries can be postponed for the couple of days if the patient is not on the high risk, and we must do estimate laboratory findings. But the main problems are emergency surgeries because we have a very short time to optimize patient's condition operatively, consider details and operating plan with surgeon. That is the main point in those patients. And second, and the very big one problem is that consider post-operative treatment in the ICU because that patients could be in the high risk of the bleeding, and we suppose that patients could have needs for the fresh frozen plasma, erythrocyte concentrate, cryoprecipitate, prothrombin complex concentrate question mark, because I sometimes I used all of that, spent everything in the patient, and without any kind of results. Should we use continuous renal replacement therapy, or should we use reversal agents for the dogs? It's also the questions which we have to consider operatively in treatment in ICU. So I would like to show you our experiences, and we have in a 4 years period, approximately 34 patients who are on drugs or Ticagrelor. I would like to show you 12 patients underwent on cardiac surgery in our, as I can say, pre-CytoSorb era. And of those 12 patients, 6 patients were on Ticagrelor, 4 patients were on Rivaroxaban, and 2 on dabigatran. Unfortunately, all those patients experienced significant intra and post-operative drainage. Average amount of drainage volumes in the first 24 hours was over the 1 liter. High average amount of red blood cells transfusions was almost 1 liter. Also the same with platelet transfusions, and high average amount of fresh frozen plasma was over the 1 liter too. So the problem is that more than half of those patients had indications for re-thoracotomy, and fortunately ICU length of stay was prolonged to approximately over the 5 days. And after those patients, today's cases, we question what to do to improve our patients' outcome. It's not so simple question. And fortunately for us, in 2017, we found a few case reports which gave us a good idea what we can do. First one was from the Switzerland, and the second one from the colleagues from Germany. And in both, they described how they use the CytoSorb in CPB, and how they purificate the dogs or Ticagrelor from the patient's blood. After that, we sit with our cardiac surgeons, which is a very experienced and good team, and start to use CytoSorb during the cardiopulmonary bypass in all our patients, which we estimate that could be on the high risk of perioperative bleeding. As you know, the put on the machine is on that way. So, additional 22 patients who underwent on cardiac surgery after we start to use the CytoSorb was on the 13 patients were on Ticagrelor, 8 patients were on Rivaroxaban, and only 1 patient was on dabigatran. Good news was that all experienced less intra and post-operative drainage. That average amount of drainage volumes in first 24 hours was only 320 mils. If you remember, on the first group was over the 1 liter. We have a less average amount of red blood cells transfusion, platelets transfusion, and a less average amount of fresh frozen plasma. And only in 8.3% of patients in our CytoSorb period era had indications for re-thoracotomy, and also we have a shorter length of ICU stay for the approximately just a little more than 2 days. This is a little table in which we have all our patients on the just short view, and this is a graph in which all of those data which I show you until now, I just put it on the to see that it could be very impressive how much we have lower columns on the when we start to use CytoSorb on the CPB. So, on the end, a few conclusions that our results have shown favorable effect of CytoSorb in patients with pre-operative who was on the DOAC or Ticagrelor therapy. The effect is achieving by absorbing medication from blood in very short time, just during the CPB. So all those patients don't need any any further usage of anything, and because the point is on the very high flow on the CPB and the purification during the usage of CPB during the surgery. It is important to have on mind that DOAC's effect could be much more prolonged because of patients' renal liver dysfunction and their years. And in that case, CytoSorb significantly decreases DOAC or ticagrelor effects. Also, we decreases the risk of our bleeding, perioperative bleeding in our patients. We decreases need for blood and blood products to use in our patients. We decreases length of ICU stay of all of our patients, of course, because we don't need re-thoracotomies, we don't need complications of high much blood transfusions. And finally, that I think that important for everybody is that significantly decreases overall cost of patients management. So that will be presentation, and thank you for your attention.